So treating connective tissue disease pulmonary arterial hypertension can be rather challenging because these patients tend to respond less well to PAH therapy and can progress despite maximal medical therapy. Additionally, there can often be occult heart failure with preserved ejection fraction in patients with connective tissue disease pulmonary arterial hypertension, or occult pulmonary venous involvement, which can also impact treatment response. My approach to treating patients with connective tissue disease PAH tends to be to perform more serial and regular right heart catheterizations, particularly with exercise, to ensure that we can detect occult heart failure with preserved ejection fraction as a cause of a patient's clinical worsening over time, and to make sure that I have the right treatment approach as I'm adding any additional PAH-targeted therapy. Although treating connective tissue disease PAH, particularly scleroderma-associated pulmonary arterial hypertension, can be challenging, on the other end of the spectrum, patients with connective tissue disease PAH associated with lupus can be rather rewarding to treat, as sometimes their pulmonary hypertension can resolve with immunosuppression. I've had patients on triple therapy for pulmonary arterial hypertension with lupus-associated pulmonary arterial hypertension who are now off of all PAH therapy. So this is a rather rare but rewarding experience in treating patients with pulmonary arterial hypertension.
Now, the guidelines struggle a little bit with this when patients have very mild disease. So let's say they're able to do most things in life, but heavy exertion, they're short-winded. Their examination and their biomarkers, such as BNP and 6-minute walk, look pretty good. The echo shows maybe just mild stress on the heart. It could be that a lot of those patients, or a certain percentage of those patients, would do okay on just one drug. It's not known for sure. But in subpopulations like PAH with connective tissue disease, where the patients tend to be more severely affected, have the additional challenge of the connective tissue disease, have a more challenging prognosis, my bias, based on my experience and my reading and interpretation of the published literature, is that that's a group where you would be inclined to do upfront combination therapy and not just approach it with just one drug, barring any extenuating circumstance.